When I was asked to give this presentation, I asked, are you sure you want me to talk about pharmacology? Say, yes, we want you to talk about the pharmacology from the perspective of the clinician who uses the pharmacology for clinical care, not as an expert. So I'm here to talk to you not as an expert, okay, but as a clinician who, well, a virologist really, and a clinician who tries to use the pharmacology in order to inform patient care. So we'll start with the case. Now, a disclaimer, the case is complex and is not your typical patient, but it is a real case. And the reason why I brought it up is because it really raises a lot of the considerations that then we will want to discuss around the pharmacology and virology and how the two come together. So let me introduce Mr. RS, who's a 67-year-old male who was diagnosed HIV positive in 1999 when he presented with cryptococcal meningitis. He had a very low baseline CD4 count, high viral load, was infected with subtype C, passed Hep B, no Hep C, and started antiretroviral therapy in 1999 with AZT, 3TC, and indinavir. Okay, so this is his treatment history. This man was quite unlucky because he developed quite significant AZT-related liver toxicity, and in the space of a few months of AZT exposure, he had already evidence on a liver biopsy of septal cirrhosis with active portal and interface hepatitis, which was linked to the exposure to AZT. So quite unlucky with that. But as you can see, because of the hepatotoxicity, initially raised transaminases, then diagnosed AZT hepatotoxicity, he changed initially to abacavir because it was felt that maybe the indinavir was contributing to the transaminitis. But then when the diagnosis came through, he was, of course, moved away from AZT and went on abacavir, 3TC, and efavirenz. Now, throughout that period, he didn't really suppress his HIV viral load, and in fact, at this point here, he had quite a high viral load rebound. He then started tenofovir, stavudine, 3TC, and Calitra, and perhaps quite predictably developed lipodystrophy, but his viral load was suppressed, so he was alive. So that's good news. Alive, but not quite looking too good, but hey. Then, things change, we become more modern, never mind the D4T, but you remember, maybe some of you will remember the era when we were using a lot of dual PI combined. So he went on tenofovir, atazanavir, and fossamprevir with a small dose of ritonavir, and had started to have episodes of low-level viremia between 50 and 600 copies. Still very good CD4 count, so doing well from that point of view. For someone who had started from such a low nadir. He then, when darunavir was introduced, was moved away from the dual PI combination and went on tenofovir, raltegravir, and boosted darunavir. And again, he had problems with low-level viremia between 50 and 200, so quite low level. He also started to have declining renal function and complained of poor memory. But he was also getting a little bit old, so we didn't really get too worried about that one. His viral load was suppressed, so good. Right, so this is another way of looking at all his treatment history where the red dots are his viral load results. So remember the high sort of viral load failure soon after starting antiviral therapy. So I'm going to show you now some of the resistance results because although I know that we get bored with numbers, I think it's important to just try and look at what exactly he developed in his virus. So he, at this point, developed mutations in the reverse transcriptase enzyme. He had 67, 70, 215, 219. So those are thymidine analog mutations associated, of course, with the AZT exposure. And then also developed the M184V, which is the 3TC. So quite extensive NRTI resistance. He then had a second test at this point here when he failed the regimen that also contained efavirenz. And at this point, remember, he was on abacavir. So he also developed another mutation, which is L74V, which is the classic abacavir mutation, and also had a couple of NNRTI mutations associated with efavirenz. So quite a resistant virus at that point. But of course, he then went suppressed. Remember, he responded quite well to the PI-based regimen, and then started to have some episodes of low-level viremia on atazanavir and fosmanprevir, and had a couple of other resistance tests. At this point, the reverse transcriptase showed none of the old mutations that had been detected before, and there was just one mutation in the protease at position 32. Okay, so then he changes. Remember, so he's now on tenofovir, raltegravir, darunavir, ritonavir twice daily, 600, 100 BID. And again, he's having some low-level viremia. So at this point, of course, the question that everybody will ask is what shall we do? His viral load is not really higher than 200 copies, so do we need to worry at all? Do we need to consider that perhaps he needs a little bit of support in terms of adherence and some other issues that may be going on with his life, which I think is always very important in every patient? Do we need to think that perhaps the viral load test is not working well? Do we request more tests? And which ones will you request? Or do we just do something about the treatment regimen? Is there any comments as anybody wants to make at this point before we? Okay, so who will do nothing?
Just go back to this overview.
The overview of the patient? Which one will it be? Will it be the red one? Yeah. Okay. So this is a man who's capable of getting suppressed, but sort of not consistently so. So my question to Charles, let me just ask Charles, I'll put him on the spot. Would you do any more tests? And if yes, what would you do?
Yeah, I could do a lot of academic tests, which wouldn't help the patient. I think I would wait a little bit, because I'm not totally convinced that what you call failure, the too low level HCV RNA copies, are true, at least true resistant failure. So I'd like to confirmation of therapy failure.
Yeah, I mean, absolutely. That's one strategy. Say, okay, he's actually considering where he's coming from, lots of resistance. In the past, his viral load is actually not too bad, and his CD4 count is good. So, you know, you could push ahead. And that is exactly what happened, of course. Let me just show you this. Okay, so before we go into what happened generally, so how we will address sort of this kind of cases is that we will obviously always address the issues of adherence, and also trying to understand if there is any impediment, any what we call psychosocial issues that may affect adherence. We also consider the viral load test performance, whether it has changed over time, whether it may perform differently relative to the past. This is sort of a general type of consideration you may also want to make. Now, of course, this is a pharmacology talk, so I was at least hoping Charles would suggest let's measure the drug levels so that I could actually tell you we've done it. But anyway, in a lot of circumstances where there is access to therapeutic drug monitoring, people will request a drug level in order to make sure the drugs are adequate, and sometimes even as a marker of adherence to ensure that there is good adherence. As to changing or intensifying the ART regimen, is already on quite a lot of drugs, so how would you go about that is obviously a little bit more complicated. So generally speaking, what do we say about these patients that present in this case? We say, of course, you do review the technicalities of the viral load testing, adherence, tolerability, psychosocial issues, the regimen that you're using. Let's not forget that this is a pharmacology presentation. We need to consider any potential drug-drug interactions, possible food requirements. Has he started any other medication that may be affecting his overall drug exposure? Perhaps he's getting a little bit older, he's getting medications from the GP that perhaps we don't know anything about. So this is something always to keep in mind, the other sort of medications patients may have started, may be taking. I think it's reasonable to perform a resistance test. How many times you do it, how frequently you repeat it is obviously not really codified, but I think it's good to at least keep an eye, if you can, on what's happening to the virus. And of course, it is reasonable in selected cases, so depending on the access you have to drug levels, to measure those. The other thing which I think is important in these patients is to look at the nadir CD4 count, because patients that present with a very low nadir CD4 count, perhaps very high pre-heart viral load, are those that have very, very large reservoirs of virus. And perhaps those are the kind of patients that may create situations that facilitate the kind of picture we're looking at. Particularly if the size of the reservoir is high, perhaps there is more scope for virus reactivation that produces viremia. And also, I think if there's been advanced disease, perhaps quite fibrotic lymphoid tissue, perhaps also the virus has had the opportunity to evolve into specific characteristics, you may have greater opportunities for compartmentalized virus replication. So I think it's important to look at this issue, how advanced the disease was in the patient. Okay. Very quickly now, a few bits of data about the viremia issue. As we know, when we start antiretroviral therapy, the viral load declines in a number of different phases, and then gets to below 50 within usually about 12 weeks. And after that, there is another phase of decline that takes the virus to, when everything is optimal, to less than about 10 copies per milliliter. But as we know, if we dig really deep enough, most patients very stably treated will have some RNA detectable in the plasma. And this is, I think, where all the discussion comes, is where is this RNA coming from, and does it really signal ongoing virus replication? Does it really signal that nothing is, that perhaps not everything is fine as far as the treatment is concerned? So there are basically a number of different issues to consider. The first is that even when you use a very successful antiretroviral therapy, there is no impact on the reservoir, on the HIV DNA reservoir. These are patients treated very stably over many years. And basically, if you compare those treated for just a few years with those treated for over 10 years, the amount of HIV DNA present in the cells doesn't really change by duration of antiretroviral therapy. So very stable reservoir. And the model that is produced at the moment, the models that are proposed, is that perhaps you could have in patients that experience viremia, you could have ongoing replication in some sanctuary sites, some compartmentalized cell types, or perhaps we are simply looking at a virus that is released from the latently infected cells and is immediately suppressed by antiretroviral therapy. Now, these two models are quite different from each other. Why? Because in the first model, you have virus which is actually replicating actively, with new virus being produced and going on to infect new cells. So there is ongoing virus replication, which creates, of course, the opportunity for the virus to evolve, for resistance to emerge, for other favorable sort of characteristics, favorable in terms of virus evolution, favorable characteristics to emerge. In these circumstances, if you like, antiretroviral therapy is only apparently doing all that it can, and we could try and improve virological control. In the other model, you simply have a reservoir of virus that in some patients is, as we said, quite large to begin with. And in that, from that reservoir, you have periodic reactivation of production of virus, reactivation of cells with virus production. The virus is released, but is immediately suppressed by antiretrovirals, so does not produce ongoing cycles of replication. So there is no scope for virus evolution. You don't see emergence of resistance. In this scenario, really, art is doing everything it can. Now, it is my opinion that these two scenarios actually probably coexist in at least a subset of patients. All right. So let's go back to the issue of the drug levels and how useful they can be. I think this is a very interesting study from Canada that looked at patients that were experiencing low-level viremia and asked the question, what are the factors that predict whether on follow-up, these patients will have a viral load going above 1,000 copies. So at the moment, they just have low-level viremia below 1,000, but if, can we identify factors that predict whether they'll go above 1,000 copies with ongoing follow-up? And what they found was that, in fact, if you take the sample with the low-level viremia and you measure the drug levels, either for the PI or for the NNRTI, and you measure the resistance in that low-level viremia sample, then you can find that the patients that have low levels of drugs, those that have resistance in the low-level viremia sample, are those at risk of rebound. So this is the first study and the only one so far, I believe, that has clearly shown that actually measuring drug concentrations at the time of low-level viremia may be informative in the sense of identifying a subset of patients with suboptimal levels who are the ones that need intervention. Okay, they were also able to show a relationship between these two parameters, so that patients that had low-level drug concentrations were also those that developed resistance more rapidly. So that's the risk of resistance according to whether you have therapeutic drug levels or subtherapeutic drug levels. Okay, let's go back to our case now. We've done a little bit of the data. So this is our patient's RS. So this is where we are. So of course, we did more resistance tests. And he had two during the low-level viremia. And at this time, there was no resistance. There was no resistance. Remember, he's now on darunavir. There is no resistance to the PI anymore. There is no NRTI resistance or NNRTI resistance detected. And also, we tested for the integrase resistance because he's now on raltegravir, and there was no raltegravir resistance. So this is a scenario where you think probably this viremia is coming from a very high reservoir and is not going anywhere, is not producing anything. That will be a very logical conclusion. So we also measured the darunavir levels, and they were in the range that was required to suppress that particular virus. All okay? Comments? No?
I have comments. If I get the microphone to work, it's not easy.
So please take a minute to explain with all the information that you have, what is your current most likely scenario for the low plasma RNA?
Yeah, so at this point, if I had not done what I'm going to tell you in a few minutes.
No, this is what we know now, and then we can, yeah?
Yes, so right now for this patient at this point.
Yeah.
So for this patient at this point in time, you will probably conclude that this is someone with a very, very high reservoir because of having experienced very advanced disease, and is possibly experiencing a high plateau of plasma viremia because he has a lot of virus coming from the reservoir. This is hypothesis one.
Can I react to it? Because it's a possibility, but given that he has been undetectable except for a blip in 2007, 2008, it could be an unlikely scenario at the same time too. So
yes,
you get into a setting where now academic parameters like proviral DNA may help to shed a light, or even,
absolutely,
right?
Yes, I agree with you. And now, he didn't have that because it wasn't part of the routine diagnostic setup, but I think these cases will be helpful to see whether the HIV DNA says above 2.5 logs, because that seems to be a reasonable cutoff for very high and not so high.
And you mentioned another hypothesis. Do you want to?
Yes, I will mention the other hypothesis, but I will only do it after I show you what happened, because otherwise I'm going to spoil the fun. So, yeah, microphone 3. Yeah. 3.
Right, thanks. Very interesting case. I mean, I was trying to take a Bayesian approach to this, where, you know, the post-test order influenced by the pre-test odds. And this is somebody who has quite a low viral load, which, to me as a clinician, I think that he has some kind of drug pressure holding that virus. So I wonder what your pre-test odds were, that there's a problem with adherence, and therefore maybe a problem with the therapeutic drug level.
You mean that the drug levels are not adequate to suppress a particular virus? Yes. I mean, he's on the maximum dose of darunavir that we could give, 600, 100 BID, and his levels of darunavir are within the expected range for the virus he's carrying. So we don't really have any evidence that we are subdosing as far as the darunavir is concerned. Yes?
I just have a question. Okay. So whether if we add lamivudine or FTC into the regimen, it's going to help or not?
Well, that's a very, 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 very good question, and we don't know the answer. So this is the issue about whether you would intensify or not. Now, strictly speaking, is old virus is lamivudine resistant. So whether it will help to have lamivudine on board by increasing sensitivity to tenofovir, by doing, some fitness effects and things like that. So that's a possibility. The fitness? Absolutely. No, I'm a believer in that. I'm a believer. I'm just showing you what happened sort of in clear case, because Charles is asking me, what is your second scenario? And the second scenario is what I already proposed, is that this is a man with a very low nadir CD4 count. There is potential here for compartmentalized virus replication. But let me just show you the data. Oh, yeah. No, sorry, I can't see it because of the light. Yes, microphone too.
Thank you for the interesting case. I'm Nicolette Okoko from Kenya. My first question is, I'm really interested in knowing what happened as far as hepatitis B is concerned for this person.
Yes.
The other thing is looking at the resistance testing, would it be proper to assume that after 5 years, even with the terms, it is possible to clear the terms, and therefore it could be possible to consider reintroducing the NRTIs to someone's regimen?
He's on tenofovir, yeah?
Yes,
so he's on tenofovir.
Oh yeah.
Yeah.
He's on tenofovir.
Yeah.
And he doesn't have resistance to tenofovir yet?
Well, he does. I mean, in the sense that his old virus will have quite a significant amount of resistance to tenofovir, not complete, but it will have some resistance to tenofovir. As to clearing the TAMs, I don't think that actually happens. They are archived in the DNA. So they've not gone. But there is the fact that the NRTIs still retain particularly tenofovir, and particularly the tenofovir in combination with 3TC or FTC, retain quite a lot of activity despite the presence of these mutations. I think that is the thing. It's not that the mutation disappears, but the drugs are still quite able to hold the virus. Perhaps, fitness effects, as Mark was saying, are quite important.
Okay. So,
yeah.
Any comment about his hepatitis B?
Hepatitis B, he had a past infection, surface antigen negative, core antibody positive, and he's now on tenofovir, so there is no concern about his hepatitis.
Yes, thank you very much for this interesting case. I just wanted to explore the problem with his memory.
Yes.
Because I think that is not so innocent. Because we are aware that there are neurocognitive disorders in infected people, and we are aware that low-level viremia is associated with increased inflammation, hypercoagulation, and cardiovascular risk, and probably subclinical strokes, which can be occurring in this patient.
Yes.
So I just wanted to know whether you looked at his lipid profile and other metabolic things and see how you can intervene.
Yes, so they will be part, yes, thank you for picking up on the poor memory, which I put there just to make sure that, it was a little trigger. But yes, he as a normal routine care with the patients, our patients will have at least once a year a check on metabolic profiles. He's fine. He doesn't have any issues with cholesterol, triglycerides, and doesn't smoke. Blood pressure is okay. So he's okay from that point of view. Shall I go on a little bit, or because there is still a lot to come, and then I'm happy to take the question if it's.
Was viral load in central nervous system assessed?
Yes, so let me just come to that. Okay.
Can
I knew that you were going to ask me that. That's why I didn't want to take the question. Yes.
Considering that you did all these genotypes, did you look at the sequences to see whether...
That was evolution?
Evolution?
No, they were really quite similar.
Okay.
The ones that done most recently were very, very similar to each other. Yeah. Okay, let me just move on. So, we did take a CSF sample. Thank you for that specific question. And indeed, there was more virus in the CSF than there was in the plasma. So we had 2 CSF samples. There was quite a bit of distance between the two because he had to travel back home for several months for family reasons. And his first CSF sample was 2,000 copies, and the second was 5,700 copies. So this is a man in whom there is low-level viremia in plasma, but actually there is a more substantial amount of virus in the CSF. Now, we done a study in the UK where we looked at how common this phenomenon is among patients who experience low-level viremia. So we took patients that had experienced at least one, usually more than one, episode of low-level viremia, defined as a viral load above 50, below 1,000 copies, and we compare the presence of virus in the CSF in these patients with those with the detection of virus in the CSF of patients that did not have a history of low-level viremia. And as you can see here, 9 out of 40 patients in the group that had experienced low-level viremia, so 22% of these patients, in fact, had a discordant CSF with higher levels of virus in the CSF than there were in the plasma. So what were the predictive factors? And this is why I was telling you about the importance of the nadir CD4 count. What we found was that the strongest predictor of having this discordance between the plasma and the CSF in these patients with low-level viremia was, in fact, the nadir CD4 count. That was very, very important. And also patients of black heterosexual exposure group also were more prone to experience this phenomenon. Whether that is probably due to the fact that they were frequently diagnosed late and therefore had a low nadir CD4 count is probably true. So that is the thing. So
can you explain again the relationship with the nadir CD4 count? So if you have a low nadir,
you're more likely to have discordance. So you have a higher CSF level than you have the plasma. So you have, this is just in the group with low-level viremia. So these are patients on ART that are experiencing one or more episodes of viremia below 1,000 copies, usually between 50 and 400, 500. When you look at this group in particular, those that were discrepant, so they had much more virus in CSF than in plasma, had the low nadir CD4 count.
But then the question is still not being addressed, so you may start to address it. Is this simply release of virus, or is this true replicative virus?
I think it's true replicating. Let me show you why.
Okay.
I think it's true replicating. And so I'll come to the conclusion in a moment. Let me just show you what happened. So we did the resistance test on the virus in the CSF. And it was a bit surprising to find that, whereas you remember all the resistance tests in the plasma basically were giving us a completely wild-type virus, in fact, the virus we amplified from the CSF on 2 separate samples was the old virus. The one that had emerged many years before had all of those mutations. But interestingly, and this is why I think this virus was actually replicating, now this virus had also acquired raltegravir resistance with the 155 mutation having emerged. So we measured the drug levels in the CSF of this patient. There were good drug levels for darunavir. There were good drug levels for raltegravir. But obviously, something was happening in terms of the activity of the protease inhibitor on the virus in the CNS that wasn't really doing what it was supposed to be doing. So what is the model that one can propose? You have a patient that experienced a very, very advanced disease, as highlighted by a low nadir CD4 count, as a time for the virus to evolve into a neurotropic virus that has seeded the CNS and has started replicating. Probably at the same time there is quite a disrupted lymphoid tissue, so that you have phenomena of ongoing virus replication in different compartments. One is the CNS, perhaps also in the lymphoid tissue, and they cause, so the low-level viremia is happening, but it's a separate phenomenon from the phenomenon that is going on in the CSF. Although the origin of the phenomenon is the same, the virus replicating the CNS doesn't seem to be the same as the virus that is generating the low-level viremia. Okay, so let me just go on and say a few things now about the PK aspects of the that we had to consider in order to define the next treatment regimen for this patient. So let's start first of all with the resistance profile. Remember, it's now developed a 155 in the CNS, in the CSF sample. We know that this is a classic raltegravir mutation. We know it also confers cross-resistance to L-bictegravir, so we could not really go from raltegravir to L-bictegravir. What about dolutegravir? Now, we know that dolutegravir is expected to work against the virus with the 155, but is it going to work completely, and is it going to be fully effective? Let's have a look at some recent data on the resistance profile of dolutegravir. These are patients who failed within the saline study of dolutegravir. Saline recruited patients who were ART experienced but integrase naive, and they received dolutegravir 50 milligram once daily together with drugs selected by the treating clinician, according to the history and resistance profile. So I have two cases here of very few patients who failed therapy, but I have two cases of patients who failed with their resistance profile. The first one is this patient who rebounded after week 84, and the resistance profile showed the classic dolutegravir mutation 263, which Mark will tell us, of course, makes the virus very unhappy. And in fact, as you can see, the viral load in this patient was in fact quite low. But interestingly, there was another patient. There were in fact two other patients that behaved like this one. This is only one of the two. And in this case, the resistance profile was quite different because the patient was found to fail with the 155 mutation. Now, what was really characteristic of these two patients that failed with this raltegravir mutation while receiving dolutegravir was that they had very low dolutegravir exposure. They had very low dolutegravir plasma levels, suggesting that perhaps the plasma levels of dolutegravir will influence also the evolution of the resistance. And I'll be curious to hear what Mark thinks about that, whether it's possible that if you have a very low drug exposure, the virus may find it more convenient, shall we say, to escape through a less crippling evolutionary pathway than the 263. So 155 can have an impact. So what can we think of using? Okay, we can use dolutegravir. Certainly we can put it there. How will you couple dolutegravir? What would you use together with dolutegravir? Would you say boosted PI is already on that, right? And we have some concerns about the activity of the PI on the brain virus. But would you say, okay, we'll just simply swap everything and give dolutegravir? Would you think you will add another drug? And if so, what? Etravirine, perhaps? The resistance profile will say that etravirine is probably quite active in this patient, although it will not be completely active because of the previous efavirenz failure with resistance. Would you use maraviroc? His virus is R5 tropic, plus we always think that brain virus is R5, so it will be good for him to have that, perhaps. Would you skip dolutegravir and give maraviroc and etravirine, or would you throw everything that you have and perhaps add tenofovir or perhaps TAF in view of his renal function on being so good? And would you use FTC or 3TC as discussed? And finally, which dose of dolutegravir would you use? Okay, I'm going to open that to the floor.
I think this patient, I mean, we're now treating a virus in the brain, right?
Yes.
In the CSF, which already you have shown that the darunavir is not doing a lot, so that's problematic. Then dolutegravir activity, whether or not it's going to be active, is really going to be potentially a function of the level of dolutegravir that you can reach in the brain.
I agree.
And
yes.
even then, the activity is already affected by the 155.
Yeah.
So that's tricky. And also, the activity of the non-nucleoside is not going to be tremendous. So, if anything, I would like to add maraviroc if it's tropic, and you could either consider to add T20 at least for some period of time, because you're really on the margin of getting a suppressive regimen.
No, T20 of course doesn't really get into the CSF, but I mean you could consider it for overall sort of virus control. But yeah.
Microphone 3. Sorry.
Yes, I think with the regimens, I totally agree what Professor Bouchard said. But there's a problem. I think etraveline is active with the profile the patient have, but there's a problem with the induction of the decreasing the concentrations of dolutegravir.
Yes.
So if you increase, I think you have to increase to double dose dolutegravir, but you have a problem if you put etraveline because you're going to decrease it again. So
I agree. So this is exactly a case where we
That's an
can't
issue.
just simply throw everything we have. We are going to have to think about the drug-drug interactions. I agree. We'll come on to that. We'll develop that. Yes. Mark. And then two, yes.
So is the patient in fact CCR5 tropic?
Yes.
So I agree then, Maraviroc could be a reasonable option. I also agree dolutegravir could be problematic because of that 155H, and 155H is the only mutation of the classical mutations that can coexist with 263K. So
Yes. Okay.
I'd be worried about evolution in that context. Maraviroc sounds like a good possibility, but I keep wondering if the patient had really never gone off the 3TC, maybe he wouldn't have wound up in trouble.
You're right. I mean, I also wondered about that.
Is there a rationale to switch to another PI just because he has proven not to do something on this boosted one?
Yes, you could also reason in that way that maybe you go from one PI to the other. That is a possibility. I didn't put it there, but yeah.
Yeah, let's get boosted saquinavir.
Yeah, saquinavir. I mean, he could go back to indinavir, which we know as a good activity in the CNS, but the toxicity profile is something else. But indinavir will be good. Yes.
Just out of curiosity, have you ruled out superinfection with another virus that was probably exposed?
Oh no, we did quite extensive phylogenetics between the viruses, and they are really consistent. The old and the one is the same virus. The CNS is the same virus as the virus that was present many years before in plasma.
You'll also soon have doravirine.
That's very true. We're going to have to look ahead, and this is a classic patient where perhaps the new drugs will be helpful. Let me just go ahead a little bit more. I got a lot of information, and then we'll come up with a regimen for this patient. So here is where the pharmacology comes, okay? The non-expert pharmacology comes. So the dose, first of all. Dolutegravir, of course, is 50, but remember it can be dosed up to 100 BID. So let's keep that thing in mind. Albitegravir, raltegravir, we know about that. So what do we know about the pharmacology of these agents? Well, they all are very potent inhibitors of the integrase enzyme, of course, and they're sort of the IC90, IC95, so the inhibitory concentration that blocks virus replication 90%, 95%. When you protein adjust for protein binding, you can see that in fact is quite the amount of drug you need to achieve a high level virus suppression is not very much, okay? So this is the simplified version of what that is. So they have a high inhibitory quotient. And in fact, if you compare the three drugs, with dolutegravir as the highest, then we have albitegravir, then raltegravir. So you have a very, very wide range of ability to suppress viruses of different susceptibilities. Of course, their pharmacokinetic and pharmacodynamic profiles are different in several aspects. And there is also intra-patient and inter-patient variability in drug exposure that is achieved with the same dosage. However, this variability is highest for raltegravir and lowest for dolutegravir, which is important. Okay, what else do we need to keep in mind about the pharmacology? I think one key aspect is the metabolism of these drugs, which is essentially hepatic metabolism, and it's different. Why? Because with raltegravir and dolutegravir, you have a minimal involvement of the cytochrome P450, abbreviated as CYP, whereas albitegravir is primarily metabolized through the CYP3A4. So what is the result of this is that with raltegravir and dolutegravir, you have a minimal, not zero, but you have a minimal potential for drug-drug interactions, whereas, of course, with L-bictegravir, number one, you need to boost to achieve adequate concentration, and you can boost through cosibistat or even ritonavir, of course, but also you have a greater potential for drug-drug interactions, which the good news is that is not that different from what we know when using ritonavir. So the cosibistat and ritonavir profiles are not identical, but they can be managed along the same lines. Okay, right, what else do we know? So what about the food effect? Remember, we are now in a case where we're going to try and optimize drug exposure because we have problems with getting the drugs where they need to be, we have problems with activity, we have partial drug resistance, we're going to have to try and maximize the circumstances for this patient. So we're going to have to start thinking about the dose, which we have done. So certainly this patient has integrase resistance, so it needs BID, but I think this is a case where you may want to push the dose to 100 BID rather than the 50 BID. Okay, so that is the one thing to remember. Then you may want to instruct the patient to take the drugs well. And so we need to think about the effect of food on drug absorption. So we know that with dolutegravir, food has an effect. And in fact, if you have, for instance, a high fat or a moderate fat meal, you can increase overall exposure to dolutegravir quite substantially. So it's a good idea to tell a patient where you need to optimize dolutegravir activity to take it with a meal, and preferably with some olive oil, for example, or some equivalent to that of fat. So that is an important consideration. Okay, this is the effect, if you like to see the effect of food. This is in healthy volunteers, the effect of taking dolutegravir, 50 milligrams in this case, with different type of foods, and you can get, obviously, with a high fat, you get the best exposure. Okay, right. What other issues do we need to consider? The fact that all integrase inhibitors, the absorption of all integrase inhibitors can be reduced by cations, such as those that you find, for instance, in multivitamins, to give you some examples. They can decrease exposure quite substantially, so make sure you know what your patient is taking. Multivitamins, very easy to buy them over the counter. Patients don't necessarily tell you that they are taking them. Make sure you ask your patient, what are you taking besides the drugs I am prescribing? So this is just to remind you of the effects of the acid-reducing agents and multivitamins on dolutegravir exposure. If you take antiacid with magnesium or aluminium, then the exposure to dolutegravir, if you take them at the same time, the exposure to dolutegravir goes down by 74%. You want to avoid that in someone, well, in everybody really, but certainly when you're trying to optimize exposure, that's not something you want. Same with calcium supplements, iron supplements, multivitamins. As you can see, quite substantial decreases, whereas omeprazole doesn't really have a dramatic impact. So ask your patients whether they are taking multivitamins and various other antacid and so forth. If it's necessary for patients to take this, then they should be separated from the dolutegravir. So what you do is that you have to instruct the patient to take them at least 2 hours after or 6 hours before dolutegravir. Okay, what else do we need to keep in mind? Protein binding is important, of course. Why is important? Because we're thinking about also activity in the penetration in the CNS and in the CSF, and protein binding, of course, is an important factor. But the other, I think, issue we want to explore a little bit is the relationship between the dose exposure, sort of the dose and overall the exposure of the drug in terms of achieving good activity. And as we said, you can go up with dolutegravir to 100 BID, and in fact, we know that there is a good dose-exposure relationship. The more you give, the more exposure you get, up to about 100 milligrams BID. So it's possible to push the dose to that level without running into substantial toxicity as far as we know so far. This is not something for which we have extensive clinical data. For the other two, the relationship dose exposure is less than dose proportional for L-bictegravir, is nearly dose proportional for raltegravir, but we're not going to worry about those right now in this particular patient. Okay. What else do we need to think about is the CSF penetration, as we said. Now, dolutegravir, highly protein bound, greater than 99% bound. There's been a study by Scott Latendre that looked, I think has now been published, that looked at the distribution of dolutegravir in the CSF. Very important to understand that. Now, what he reported was that the concentrations of dolutegravir in the CSF basically exceeded the IC50 for wild-type virus. So they are okay, but for wild-type virus, you're dealing with a resistant virus here, and you're dealing with a patient in whom the other drugs you may have in the regimen, particularly your boosted PI, may not be doing everything they need doing on that brain virus. So make sure you're giving enough dolutegravir. Again, a case for pushing up the dose to 100 BID. Special groups. Remember what I told you at the very beginning. This patient has a declining renal function. You're going to have to watch it really carefully. Why that is? Because there is a correlation between renal impairment and dolutegravir exposure that we do not understand. In other words, patients with severe renal impairment have a reduced exposure to dolutegravir. We don't know why that is, because of course the drug is metabolized through the liver, so we don't understand why patients with severe renal impairment should have overall less exposure to dolutegravir, but it has been shown, and so that's something we need to keep in mind. Now, this patient doesn't have severe renal impairment, but remember, we are dealing with a degree of renal impairment, which again may have an impact on dolutegravir exposure. So another case for making sure you're giving enough dolutegravir in this patient. You don't need to dose adjust for renal impairment, but keep in mind the issue of renal disease and dolutegravir exposure. Okay, moving on. So this is to show very quickly the relationship between the dose and the exposure. So the more you give, the more you get up to, this is up to 50, but in fact it's also true up to 100 milligrams. And in fact, patients, if you look in vivo in terms of virological responses, and you correlate virological responses to the drug levels, what we call the pharmacodynamic aspects of dolutegravir therapy, then you can see that patients that have the best levels also achieve the best virological responses. Right, now, drug-drug interactions. So we have already discussed some of the issues we need to consider. What else do we need to keep in mind? So we discussed just the importance of looking at magnesium, aluminum, calcium, supplements, multivitamins, and how to take it, and so forth. I also want to show you some other important issue. This is a man who's aging. You rightly asked me about metabolic issues. It's not uncommon for people who are older to start getting on metformin and things like that. So remember this important drug-drug interaction between dolutegravir and metformin. And here is the updated recommendation. Basically, you need to be careful with the dosing of metformin. You need to limit the total daily dose to not more than 1,000 milligrams. And you need to, if you then at any point decide to stop the dolutegravir, you may need to readjust the dose of metformin. Basically, patients who need the two drugs together, metformin and dolutegravir, you need to really monitor the blood glucose, because you may not be getting the activity that you desire, and you may basically overexpose the patient to metformin. Other drug interactions are listed here: carbamazepine, rifampicin, efavirenz, nevarapine, tipranavir. Just, yeah, make sure you look at that. Now, what about other antiretrovirals? We're coming towards the end. We're going to come together, all this data together, and recommend the regimen. But just to remind you exactly what you were pointing out, the issue of the negative interaction between dolutegravir and atravirine that you need to think about. Now, we've done a lot of discussion about making sure this patient has adequate exposure to dolutegravir. Take with food, don't take antacid, don't take the multivitamins, all separate, make sure that you give enough, look at the renal function, and so forth. But if you then combine it with atravirine, you may find that all these efforts that you have made actually get wasted, because atravirine has a substantial impact on dolutegravir exposure and will reduce dolutegravir exposure by 88%. So you need to think, when you are trying to combine all the drugs together, you need to think, how much activity will etraverin contribute in this patient relative to how much are you probably taking away from the dolutegravir exposure. But let me show you those data in particularly, here they are, so these are the curves. This is when you take dolutegravir with etraverin without also having a boosted PI. So there is quite a reduction, as we said, in the exposure to dolutegravir, really quite sharp. This is reduced if you also add a boosted PI, but again, you don't really get to the levels that you will achieve if you didn't have etraverin on board. So the equation here is not to use etraverin. You could use dolutegravir and etraverin together if you also have a boosted PI, but keep in mind that you'll be subtracting some activity from the dolutegravir in terms of drug exposure and therefore activity, and therefore you need to ask yourself how much activity are you gaining from etraverin that will justify taking a bit away from the dolutegravir. Make sense? Very good. Okay, coming towards the end, of course, so I work in Liverpool, and we have this website that we manage, that is the drug-drug interaction website. So you can log in, put all the drugs you want to use, including non-HIV drugs, and ask the question, what are the drug-drug interactions? So I did that for our patient, and I put in everything that we are considering, and basically these are the drug-drug interactions that we need to be cautious about. They are yellow, so they are amber. So we need to think that if you combine the etraverin with maraviroc, you reduce exposure to maraviroc, and if you don't use a boosted PI, you need to use maraviroc 600 milligrams twice daily. If you also have a boosted PI, you will use 150 BID, which is the standard dose with the boosted PI. But keep in mind, again, etraverin will reduce some exposure to maraviroc. Ritonavir, of course, in your regimen will boost maraviroc, and that's why you can use 150 milligrams BID. Ritonavir with dolutegravir, we don't have a very good data, but there is a potential for a slightly reduced exposure to dolutegravir. Of course, this is not something we can circumvent in this particular patient, I don't think. But etraverin with dolutegravir, of course, there is a big warning that this is bad news for dolutegravir. All the other drugs can be used together without any problem. So I would say that probably etraverin here is our problem. Okay, so this is what we did, and of course this is open to criticism and absolutely, and feedback, but what was decided was that he will get darunavir boosted at the twice daily dosing, which he's already taking anyway, with dolutegravir at the dose of 100 milligrams BID and maraviroc 150 BID. We decided to add tenofovir and FTC until we're able to repeat the CSF lumbar puncture, which is not terribly keen to have. And as soon as we sort of can have that result, if we are happy that the virus is suppressed also, we will try and perhaps simplify a little bit more, depending obviously on the viremia in the plasma as well as in the CSF. Of course, remember that we don't expect tough tenofovir to have great CSF penetration, but overall we hope that we are able to improve general control of virus replication in this patient. And I think before I open to criticism, I want to thank my colleagues, the experts in pharmacology from the University of Liverpool, Seiku and David Back, who gave me some of their slides, and I would also like to thank Romina Quercia from VIF, who shared with me some of the VIF slides for dolutegravir, which I showed you. Thank you very much.